Hello. This is the third lecture of this educational material, and it is focused to the management of Parkinson's disease. In this session, we will discuss about the available pharmacological treatments for Parkinson's disease and the surgical options that exist for the advanced Parkinson's disease. We will also discuss about the importance of directing patients and carers to good sources of information and about the role of occupational therapy for managing everyday life. Then we will see how practical advice and adaptive aids can keep patients independent for as long as this is possible. But Parkinson's disease is a complex disorder, and we have to realize the importance of multi-professional, interdisciplinary, and continuous management of it. Working in a multi-professional team, every health professional has to understand his or her limits and decide who is the best source to give sufficient answers for questions about the disease. Finally, we will discuss about the role of complementary therapies for Parkinson's disease. First of all, we will see the available pharmacological treatments for Parkinson's disease. Currently, there is no proven neuroprotective or disease-modifying therapy that can stop or delay the progress of the neurodegeneration in Parkinson's disease. So the goal of medical management is to provide control of signs and symptoms for as long as possible while minimizing adverse effects. Levodopa, a prodrug of dopamine, was first shown to be effective for the reduction of the intensity of Parkinsonian symptoms in experimental animals about 70 years ago. 20 years of research was needed for the ramification of its dose and use in patients with Parkinson's disease. Today, levodopa, coupled with a peripheral decarboxylase inhibitor, remains the gold standard of symptomatic treatment for Parkinson's disease. We will discuss about drug therapy for Parkinson's disease, making a necessary demarcation between early disease and advanced disease. So, for early disease, levodopa coupled with carbidopa or benzocaide is one option. Levodopa crosses the blood-brain barrier, whereas dopamine itself cannot. Thus, levodopa is used to increase dopamine concentrations in the central nervous system. Once levodopa has entered the central nervous system, it is converted into dopamine by the enzyme aromatic L-amino acid decarboxylase, also known as dopa decarboxylase. Carbidopa or benzocaide inhibit the decarboxylation of levodopa to dopamine in the systemic circulation, allowing for greater levodopa delivery into the central nervous system. Levodopa has the greatest anti-Parkinsonian benefit with the fewest adverse effects in the short term. Another option for symptomatic therapy in early disease is monoamine oxidase B inhibitors. These agents, seleduline and risaduline, increase the amount of dopamine that is available in the synaptic terminals of dopaminergic neurons and can be used either as initial treatment monotherapy or as adjunctive therapy. They provide only mild symptomatic benefit, but they have excellent adverse effect profiles, and may improve long-term outcomes. There are some studies that also support the neuroprotective role of these medications but other not. So the overall results are controversial for neuroprotection, and monoamine oxidase B inhibitors are used as symptomatic treatment. Then, dopamine agonists can also be used for treatment in early disease either as monotherapy or in combination with levodopa. The agents included in this category are pramipexole, ropinirole, and rotigotine. The first two are available as tablets and the later as transdermal patch. These medications stimulate dopamine receptors in striatum and provide symptomatic benefit that is comparable to that with levodopa coupled to carbidopa in early disease. Initial treatment with a dopamine agonist, to which levodopa can be added as necessary, is associated with fewer motor fluctuations and dyskinesias than levodopa alone in prospective, double-blind studies. However, these agents have more adverse effects than levodopa, including sleepiness, hallucinations, edema, and impulse control disorders, especially in patients older than 70 years old, so they are reserved for younger patients, and patients without comorbidities. Anticholinergic agents can be used for patients who have disability due to tremor that is not adequately controlled with dopaminergic medication. But these are not first-line drugs, because of their limited efficacy and the possibility of neuropsychiatric side effects. Anticholinergic medications provide good tremor relief in approximately 50% of patients but do not meaningfully improve bradykinesia or rigidity. Adverse cognitive effects are relatively common, especially in elderly persons, as well as confusion and hallucinations. Amantadine is an antiviral agent that has anti-Parkinsonian activity. Its mechanism of action is not fully understood, but amantadine appears to potentiate central nervous system dopaminergic responses. It may release dopamine and norepinephrine from storage sites and inhibit the reuptake of dopamine and norepinephrine. Amantadine may offer additional benefit in patients experiencing maximal or waning effects from levodopa. The most concerning potential side effects of amantadine are confusion and hallucinations. Common side effects include nausea, headache, dizziness, and insomnia. Less frequently reported side effects include anxiety and irritability, ataxia, livedo reticularis, which expresses itself as a lace-like purplish discoloration of the skin, and furthermore, peripheral edema, and orthostatic hypotension. Initially, drug treatment for early disease provides sustained benefit throughout the day. However, after several months to years, many patients encounter motor problems like freezing of gait, motor fluctuations, or levodopa-induced dyskinesias. Freezing of gait is a brief and episodic absence or marked reduction of forward progression of the feet despite the intention to walk, and it reflects a combined motor and cognitive deautomatization deficit. Its prevalence increases with longer disease duration, and it is 7% for patients in early disease and more than 50% in advanced disease. It is one of the most debilitating motor symptoms and the main cause of falling, fracture risk, activities of daily living disability and loss of independence. Patients initially in the early stages of the disease experience stable, sustained benefit through the day in response to levodopa. However, after several months to years, many patients notice that the benefit from immediate release levodopa coupled to carbidopa wears off after 4 to 5 hours. Over time, this shortened duration of response becomes more fleeting, and clinical status fluctuates more and more closely in concert with peripheral levodopa concentration. Ultimately, benefit lasts only about 2 hours. The time when medication is providing benefit for bradykinesia, rigidity, and tremor is called on time, and the time when medication is not providing benefit is called off time. By several months to years after the introduction of levodopa, many patients develop peak dose dyskinesia consisting of involuntary movements, such as choreiform, dystonic or myoclonic movements that occur when dopamine levels are very high. At this point, increasing dopamine stimulation is likely to worsen peak dose dyskinesias, and decreasing dopamine stimulation may worsen Parkinson's disease motor signs and increase off time. The therapeutic window lies above the threshold required to improve symptoms on threshold, and below the threshold for peak dose dyskinesia, which is called the dyskinesia threshold. The therapeutic window narrows over time because of a progressive decrease in the threshold for peak dose dyskinesia. Another form of levodopa-induced dyskinesias is diphasic dyskinesia, appearing at the onset and offset of the levodopa effect, coinciding with a rising and decaying plasma levodopa levels. The most dominant manifestation of diphasic dyskinesia are the repetitive alternating movements in the limbs, usually of a dystonic nature. Let's see now the available treatments for motor symptoms in advanced Parkinson's disease. First of all, freezing of gait. Levodopa has been shown to be effective in the treatment of freezing of gait, but fine-tuning of dosage, preferably in the immediate release tablets, is important in order to get the optimal result. Furthermore, Other drug delivery methods like sustained-release tablets, inhaled or intrajejunal infusion, can achieve continuous levodopa supply and may provide even better effectiveness. Monoamine oxidase B inhibitors have also shown effectiveness for the management of freezing of gait in some studies. For the treatment of motor fluctuations, the following strategies can be followed. First of all, dosing levodopa more frequently and increasing the levodopa dose. Secondly, interventions to improve bioavailability through better absorption from the gut, such as an empty stomach, proteins or constipation. Thirdly, adding a dopamine agonist, catechol-O-methyltransferase or COMT inhibitor, monoamine oxidase inhibitor, subcutaneous apomorphine or selective adenosine antagonist. Fourthly, adding intermittent levodopa inhaled doses. Fifthly, switching from immediate release to sustained release levodopa carbidopa, or levodopa carbidopa and entacapone. And finally, continuous intrajejunal infusion of a carbidopa levodopa enteral suspension could be beneficial. Unless limited by the emergence of peak dose symptoms such as dyskinesia or hallucinations, dopaminergic therapy should be increased until off time is eliminated. For the treatment of levodopa-induced dyskinesias, the same strategies should be followed. Fine-tuning of levodopa dosage, dosing more frequently and/or decreasing the dose for peak dose dyskinesia, adding an adjunctive treatment to levodopa, such as amantadine. Other drug delivery methods for levodopa may provide better effectiveness. Motor fluctuations and dyskinesia are usually present together in advanced disease, making symptomatic therapy very challenging. The therapeutic window lies above the threshold required to improve symptoms on threshold and below the threshold for peak dose dyskinesia, which is called dyskinesia threshold. The therapeutic window narrows over time because of a progressive decrease in the threshold for peak dose dyskinesia. For all these patients with advanced Parkinson's disease, as we saw, currently levodopa remains the gold standard of treatment, and alternative drug delivery methods may provide better effectiveness. Inhaled levodopa was approved in 2018 in USA for intermittent treatment of OFF episodes in patients who are already treated with oral carbidopa coupled to levodopa. The inhaled dosage form bypasses the digestive system, thereby providing a quick onset of action as soon as 10 minutes. Another option is the use of sustained-release levodopa carbidopa tablets. Levodopa carbidopa is also available in combination with entacapone, a catechol-O-methyltransferase inhibitor. When entacapone is given in conjunction with levodopa and carbidopa, plasma levels of levodopa are higher and more sustained than after administration of levodopa and carbidopa alone. Levodopa carbidopa and entacapone is useful in advanced Parkinson's disease in patients with motor fluctuations. A carbidopa-levodopa enteral suspension, duopa gel that is infused into the jejunum by a portable pump, is now available. The efficacy of the enteral suspension to decrease off time and increase on time is significant and was shown in several studies. George Coetzee, as shown in picture, was the scientist who together with his co-workers developed levodopa treatment in 1968. But apart from motor symptoms, patients with Parkinson's disease develop a number of non-motor symptoms. These symptoms aggravate with the progression of the disease, and they can be even more disabling than the motor symptoms. For dementia in Parkinson's disease, cholinesterase inhibitors and an N-methyl D-aspartate receptor antagonist have been shown to be possibly effective. Depression is one of the most common non-motor symptoms of Parkinson's disease, occurring in approximately 35% of patients. Depression in Parkinson's disease has a profound impact on quality of life, and is associated with reduced function, cognitive impairment, and increased caregiver stress. Positive results on depression have been demonstrated for SSRIs, SNRIs and tricyclic antidepressants. The same agents as well as benzodiazepines may be beneficial for anxiety too. Anti-Parkinsonian drugs can trigger psychosis in patients with Parkinson's disease. In Parkinson's disease patients with psychosis, anti-Parkinsonian medications other than levodopa should be withdrawn in an effort to resolve psychosis while maintaining motor control with levodopa. In individuals with only mild hallucinations that are well tolerated, active antipsychotic treatment may not be necessary. Use of typical antipsychotics can exacerbate motor symptoms of Parkinson's disease and should be avoided. Atypical neuroleptic agents, most often quetiapine, and clozapine rarely exacerbates motor symptoms, and they are broadly used to control psychotic symptoms in Parkinson's disease. For impulsive behaviors only the opioid antagonist naltrexone has been shown some improvement, and the cognitive behavioral therapy. Sleep disturbances in Parkinson's disease can be in the form of REM sleep behavior disorder, RBD, that can respond to benzodiazepines and sleep hygiene techniques. On the other hand, modafinil can be used for patients with excessive daytime somnolence, EDS. Let's see now the surgical options for Parkinson's disease. There are two different kinds of surgeries: neuroablative lesion surgeries and deep brain stimulation. For the first category of surgical procedures there are three kinds of surgeries: thalamotomy, pallidotomy, and subthalamotomy. For the second category the targets are also globus pallidus and subthalamic nucleus. Lesion surgeries involve the destruction of targeted areas of the brain to control the symptoms of Parkinson's disease. Lesion surgeries for Parkinson's disease have largely been replaced by deep brain stimulation. During neuroablation, a specific deep brain target is destroyed by thermocoagulation. A radiofrequency generator is used most commonly to heat the lesioning electrode tip to the prescribed temperature in a controlled fashion. These surgeries for Parkinson's disease have largely been replaced by deep brain stimulation. Thalamotomy involves destruction of a part of the thalamus, generally the ventralis intermedius, to relieve tremor. The ventralis intermedius nucleus is considered the best target for tremor suppression, with excellent short and long-term tremor suppression in 80 to 90% of patients with Parkinson's disease. Thalamotomy has little effect on bradykinesia, rigidity, motor fluctuations, or dyskinesia. When rigidity and akinesia are prominent, other targets, including the globus pallidus interna and subthalamic nucleus, are preferred. Pallidotomy involves destruction of a part of the globus pallidus interna. Pallidotomy studies have demonstrated significant improvements in each of the cardinal symptoms of Parkinson's disease: tremor, rigidity, bradykinesia, as well as a significant reduction in dyskinesia. With 3.6%, the most serious and frequent adverse effect of pallidotomy is a scotoma in the contralateral lower central visual field. This complication occurs when the globus pallidus interna lesion extends into the optic tract, which lies immediately below the globus pallidus interna. The risk of visual field deficit is reduced greatly by accurate delineation of the ventral globus pallidus interna border by microelectrode recording. Less frequent complications, less than 5%, include injury to the internal capsule, facial paresis, and intracerebral hemorrhage, with 1 to 2%. Abnormalities of speech, swallowing, and cognition may also be observed. Bilateral pallidotomy is not recommended because complications are relatively common, and include speech difficulties, dysphagia, and cognitive impairment. Hyperactivity of the excitatory subthalamic nucleus projections to the globus pallidus interna is a crucial physiologic feature of Parkinson's disease. Subthalamotomy involves destruction of a part of the subthalamic nucleus. Although lesioning the subthalamic nucleus usually has been avoided because of the concern about producing hemibolismus, results obtained by experimental lesions of the subthalamic nucleus in animals and humans suggest that subthalamotomy may be performed safely and may reverse Parkinsonism dramatically. Subthalamotomy studies have shown significant improvements in the cardinal features of Parkinson's disease, as well as the reduction of motor fluctuations and dyskinesia. Deep brain stimulation, DBS, has become the surgical procedure of choice for Parkinson's disease for the following reasons. It does not involve destruction of brain tissue. It is reversible. It can be adjusted as the disease progresses or adverse events occur. Bilateral procedures can be performed without a significant increase in adverse events. Furthermore, a better understanding of basal ganglia physiology and circuitry and improvements in surgical techniques, neuroimaging, and electrophysiologic recording have allowed surgical procedures to be performed more accurately and with lower morbidity. The indications for deep brain stimulation in subthalamic nucleus and globus pallidus internal in patients with Parkinson's disease are the following. Firstly, the presence of motor complications refractory to medical therapy. Secondly, the absence of significant comorbidities in a biologically fit individual. Thirdly, the absence of significant mental health problems, for example, depression and dementia. And finally, response to levodopa. It is important to note for patient selection, that appropriate patients should continue to experience a good response to levodopa, but that response cannot be adequately maintained throughout the day or is complicated by excessive dyskinesia. The effectiveness of subthalamic nucleus and globus pallidus internal. Deep brain stimulation in carefully selected patients with advanced Parkinson's disease fulfilling the indications for the procedure, has been shown in several studies. Bilateral DBS was more effective than best medical therapy in improving on time without troublesome dyskinesia, motor function in general, and quality of life. It was also effective in ameliorating pain related to Parkinson's disease. On the other hand, DBS was associated with an increased risk of serious adverse events. The use of deep brain stimulation has been also tested for early Parkinson's disease, in conjunction with post-medical therapy, and it had benefits in the course of Parkinson's disease, before the appearance of severe disabling motor complications. It was also superior to medical therapy alone on several measures of quality of life and motor function. But serious adverse events observed in the study do not justify the use of deep brain stimulation in early disease. Specifically, 54.8% of the patients in the deep brain stimulation group experienced adverse events, with 17.7% of patients suffering serious adverse events related to surgical implantation or the neurostimulation device. So deep brain stimulation is reserved for patients with advanced Parkinson's disease. Apart from drug and surgical therapies, physicians and other health professionals are responsible for directing patients and carers to good sources of information. As we stated before, currently there aren't any treatments with proven neuroprotective action for Parkinson's disease. All our therapeutic interventions aim to decrease the severity of Parkinsonian symptoms, while Parkinson's disease invariably progresses with time. This leads to aggravation of symptoms, and treatment needs to be adjusted, and this goes on and on. So, in order to get the best treatment outcome, a close cooperation of health professionals with patients and carers is absolutely needed. Their active participation in decision-making about the treatment options guarantees the best result. Thus, patients and caregivers need to be well informed about Parkinson's disease, about symptoms, treatment strategies and prognosis. This kind of information is broadly available nowadays, from different sources, especially in the internet, but people without any relevant background can easily be misled by information that either overestimate or underestimate the severity of the disease. Health professionals are responsible to guide patients and caregivers to reliable sources that can help them cope with the situation. An important part of the therapeutic efforts against Parkinson's disease is the occupational therapy for managing everyday life. Motor, cognitive and/or emotional symptoms in Parkinson's disease often lead to restrictions, affecting a range of activities and limiting participation in activities of everyday life. The goal of the occupational therapy is to help patients overcome these restrictions and manage everyday life. The best outcome is achieved with occupational therapists that have access to knowledge and skills concerning Parkinson's disease and are aware of ways to identify each patient's key concerns. Early intervention with occupational therapy is important in order to establish rapport, develop a connection, understanding and trust with the therapist, prevent activities and roles being restricted or lost and, where needed, develop appropriate coping strategies. This is a patient-centered assessment and intervention, so occupational therapists work on the development of goals in collaboration with the patient and carer, and they have to adjust these goals continuously as the symptoms of the patients change with the progress of the disease. Therapists also employ a wide range of interventions to address physical and psychosocial problems to enhance participation in everyday activities such as self-care, mobility, domestic and family roles, work and leisure. Another important point is giving patients practical advice and aids for keeping independent. Despite appropriate treatment and occupational therapy, patients develop symptoms that worsen over time and restrict activities of everyday life. Practical advice from health professionals are important for patients in order to help them to cope with the difficulties they encounter, to optimize the way they perform important daily activities and to avoid activities that are beyond their capability and may be dangerous and harmful, such as danger of falls and fractures. Another measure that has been developed for patients with Parkinson's disease is the use of adaptive aids. These are devices designed to make patients' daily life easier and safer and improve their quality of life, like shower chairs and grab bars. Practical advice and adaptive aids can help patients stay as independent as possible for as long as possible. So, it is important that health professionals ask patients and caregivers often about difficulties in their everyday activities in order to identify early enough conditions that can be managed. We will discuss the importance of multi-professional, interdisciplinary and continuous management of Parkinson's disease. This topic will be presented more thorough in the next lesson. Given the complexity of Parkinson's disease and the failure of current pharmacological and surgical treatments to control the disease in a satisfactory way, a multidisciplinary approach appears to be preferable to achieve optimal therapeutic efficacy. Such a multidisciplinary approach combines pharmacological and non-pharmacological therapies, including a contribution from a variety of non-medical health professionals. A multi-professional and interdisciplinary team for management of Parkinson's disease involves a number of allied healthcare specialists, along with treating physicians. Such a team includes psychologists, physiotherapists, occupational therapists and speech therapists, as well as dietitians, social workers and sexologists. The multi-professional team focuses on the impact of the disease processes on everyday activities and offers a continuous management of Parkinson's disease adapting to the needs of the patients. But in this kind of management it is important that all parties are able to understand one's professional limits and decide who and what is the best source to give and get sufficient answers. As part of a multi-professional team, all health professionals involved in the management of patients with Parkinson's disease have to understand their limits. In this way, they can provide information to the patients, related to their field of expertise, and then guide them to the best source to give sufficient answers, for questions that are beyond their disciplines. This approach ensures that patients always get the information they need from the best source. And finally, we also have complementary therapies for Parkinson's disease. Patients with Parkinson's disease very often trust the so-called complementary therapies for their disease, that are non-mainstream methods used in conjunction with conventional medicine. Complementary therapies for Parkinson's disease include dietary modifications, for example protein and caffeine intake, supplements and vitamins, such as coenzyme Q10 or ginkgo biloba. And very important, exercise, such as practicing Pilates, dance therapy or running. Most of the complementary therapies have reasonable justifications based on mechanism of action and current theories on causes of neurodegeneration in Parkinson's disease. Few of them have documented evidence of benefit, but most of them have few risks and side effects. So, they can be considered as acceptable add-on therapies, although some are very expensive. There is evidence of symptomatic benefit for some of these therapies, but more research is needed to establish their efficacy.